Welcome to AETCM. 63-year-old male was brought to the ER with complaints of high-grade fever and chills and dry cough since 1 week. It was associated with productive cough and breathlessness since 1 week. Initial
Which all conditions you get chills along with fever?
UTI,
Urinary tract infection. Malaria. Then pneumonia, consolidation. Mostly pneumococcal. Then abscess, pus somewhere in the body. These are the common conditions which can produce chills. Okay.
Initial 10-second assessment. Patient was conscious and oriented, obey commands. Primary survey. Coming to airway, patient with no pooling of secretion or abnormal airway sounds.
Can pneumonia produce altered sensorium?
Yes, sir.
Why? It's called as toxic encephalopathy. Hypoxemia itself can produce sometimes encephalopathy. Other than the toxicity can produce altered behavior.
He was able to talk normal and able to complete full sentence. C-spine appear normal.
What is the importance of able to complete one sentence? Able to full one sentence. You are telling every case. What is the importance? So whenever there is distress, patient will not be able to talk properly. That's why we are telling patient is able to talk full sentence. So that means he is not in respiratory distress, but he is having respiratory problem. Suppose somebody is having severe asthma, he will not be able to talk at all.
Breathing on auscultation, chest bilaterally equal, air entries with bilateral wheezing and crepitation plus, left side more than right side.
So in that condition, you have to ask the patient to cough and you have to auscultate again. Then only you have to confirm your finding. Okay.
He had respiratory rate of 30 per minute and oxygen saturation of 92% in room air. Coming to circulation, good peripheral pulses.
Respiratory rate is 30, oxygen saturation is 92. What are the reasons for tachypnea? Tachypnea in emergency room. Hypoxia, one of the common cause. Here hypoxemia is there. Then metabolic acidosis is the next important cause. Then hyperventilation syndromes. It can be psychological, it can be due to central cause. Okay. These are the common conditions what we see in emergency room. Like mostly it is hypoxemia. Second thing is metabolic acidosis. Third one is anxiety, hyperventilation syndrome. Okay.
Circulation, good peripheral pulses, pulse rate of 100 per minute and blood pressure of 90/70 millimeter mercury. Disability, GCS E4, B5, M5, M6, 15/15.
90/70.
90/70, sir.
What is the age of the patient?
63,
male,
sir. Male.
Do you think that this BP is normal for this patient?
Low BP.
Slightly low. Normally, 60-year-old male patients will have slightly higher BP, or even if it is normal, it will be upper limit of the normal because of the arteriosclerosis. Many will have a slightly higher systolic BP. Here it is 90/60, 70. So you think it is normal?
No, sir.
What happened? What is happening to the BP? BP is low. You think it is low?
Yes.
Is it physiologically low, or that means he is having low BP for a long time, or due to this infection it is?
Due to this infection.
What is the first sign of hypotension? Tachycardia. Here you are telling pulse rate is only 100. Normally when the BP is very low like this, you get a higher heart rate. Either the like whatever you are documented is wrong, or there may be some other reason to reduce the heart rate. What are the reasons which can reduce the heart rate in a sepsis? Like you are telling 100 only heart rate, but BP is very low. Comparing its normal BP maybe 130, 90 or something. It is low. We don't know what is his BP, but even then, mostly this type of patients will have a BP of 130/90. But here it is heart rate is only 100. That means there is something has reduced the heart rate, or something is preventing the heart rate to increase. Either your method of examination or your documentation is wrong, or some other reason is there. What are the reasons which can reduce the heart rate in a hypotensive patient due to sepsis? He is a elderly individual. Beta blockers. Commonest cause is patients on beta blocker. That is the first and important cause which can reduce the heart rate. Second thing, carditis, myocarditis. Myocarditis can produce both tachycardia and bradycardia. When the conduction system is involved, it can produce bradycardia. Okay, so that we have to keep. Or patient can have conditions like hypothyroidism or something like that. So we have to remember all these things. BP is low, but heart rate is not increased. What is the reason? That is very important. Okay.
Exposure, temperature 97.8, adjacent to primary survey.
What is the importance of exposure and temperature in a patient with sepsis? High fever is not a problem. Anybody is having infection, high fever has to be there. That everybody know. Why an emergency doctor should be concerned about exposure and temperature in a septic patient or septicemic patient? Hypothermia. Hypothermia is one of the most dangerous prognostic factor in sepsis patient. If you keep the patient without covering the patient in emergency room, that too AC cold emergency room, mortality can be high. So exposure is very important. Maintaining body temperature to higher level is very important. Low temperature can actually kill the patient. What are the triads in sepsis or trauma patients which can aggravate the problem? One of the problem is hypothermia. Okay.
ABG, pH 7.51 and PCO2 is 29.4, bicarbonate 23.5 and PO2 is 62.2, creatinine 0.69.
What is abnormal in that? Anything abnormal?
No, sir.
Everything is normal.
PCO2 is low.
PCO2 is?
29, sir.
29. PCO2 is 29, PO2 is?
62.
Both are reduced. That means what? Oxygen is reduced, CO2 is also reduced. What do you suspect then? Suppose you have acute pneumonia. Acute, not like 5-6 days. It is acute 2-3 days pneumonia. What is the first sign? What is the respiratory rate here? High. So you have tachypnea. But even after tachypnea, oxygenation is not increasing. But what happened to the carbon dioxide? It will be washed out. So that is the first sign of respiratory distress. Hypoxemia with hypocarbia. After sometimes what will happen? Hypoxemia with hypercarbia. Then what will happen? Hypoxemia, hypercarbia, respiratory acidosis. Then only compensation occurs. Okay.
ECG, sinus tachycardia with heart rate of 104 per minute with no significant ST changes.
Okay.
Coming to secondary survey, 63 years old male came to the emergency room with a history of high-grade fever with chills and trachea since 1 week associated with productive cough with mucopurulent sputum. And breathless breathing difficulty was initially MMRC grade 1 and which was progressed to grade 3 in 1 week associated with decreased appetite but no significant no history of loose stools, abdomen pain, vomiting, no chest
Why
pain.
you are thinking about loose stools in a patient with a respiratory infection? Atypical pneumonia. Atypical pneumonia, one of the presentation is loose stools.
And for this complaint, the patient went to nearby hospital and diagnosed as pneumonia. Hence, patient was referred to our hospital for further management and evaluation. Allergic history, no significant allergy history or to any drugs or dust. Past medical and surgical history. History of, is a known case of COPD and history of benign prostate hypertrophy for which TURP was done 4 months back.
He is a non-COPD patient. He is a smoker, non-COPD patient. TURP
Was done 4 months
everything, that is a secondary problem. He is a non-COPD
COPD.
patient. How do it differ from a patient who is having fresh lung or a normal lung? How do an infection differ from a COPD patient to a person with normal lung? A normal person is getting pneumonia. A patient who is having COPD is getting pneumonia. What is the difference?
COPD will be triggered exacerbation.
In fact, all COPD exacerbations are infective exacerbation. So a person coming from community who is having pneumonia coming to your hospital, person who is already having COPD is also coming from community to your hospital with a pneumonia. What is the difference between these two pneumonias? Fresh lung pneumonia, that means a normal lung pneumonias are mostly gram positive cocci, virus or gram positive cocci. But a damaged lung person who is having pneumonia means it can be gram positive or gram negative, both are possible. Okay, so here we have to think about gram negative. So other condition we are not thinking about gram negative, mostly it is gram positive. So that is a major difference. When you are starting antibiotic, you have to cover gram positive in a normal lung person with pneumonia. Here you have to start antibiotic with gram positive, gram negative coverage. Okay.
No history of hypertension, diabetic and tuberculosis. There is no significant past history of relevant for his present complaint. General examination. Patient conscious and oriented, poorly built and averagely nourished. On examination, left supraclavicular lymph node seen.
Left.
No pallor, no iterus, no club.
You have to tell lymph node properly. What is the size of the lymph node? Whether it is hard, mobile, fixed.
It's mobile.
Mobile. Only one node.
One node, sir.
It's hard or soft?
Soft.
Painful, non-painful,
Non-painful.
fixed, non-painful, small node. Okay. So left supraclavicular lymph node has got some importance. That's why I'm asking. What is the importance? Left. Why left is very important?
Thorax.
Thoracic duct. It crosses to opposite side, goes to left. From where it comes? Thoracic duct not only drain from the lungs, it drains from the lower abdomen onwards. So any lesion in the scrotum, abdomen, everything can go directly to the left supraclavicular. This is called as, what is that node called as? Virchow node. So that is a sign of malignancy in the abdomen or below, like in the below the diaphragm. But it is all lymph nodes are always not malignant. So you have to examine. You have to, suppose you have a doubt, you have to take a biopsy or FNAC. But left-sided lymph nodes, supraclavicular lymph nodes are always important. Okay, you have to keep in mind.
Pulse rate of 100 per minute and BP was 90 to 70.
What is the drainage of lungs, lymph node wise? Where it drains? Suppose you have a problem in the lungs, where it drains? The pleura drain to axilla. Other one straight to the supraclavicular node. Okay. Mediastinum, then supraclavicular node.
Systemic examination. Respiratory rate. Air entry bilaterally equal. Bilateral crepitation and wheeze on left side more than right side. Cardiovascular system. S1, S2 heard. No murmur, no added sound. Gastrointestinal system. Per abdomen soft, non-tender and no palpable mass. Central nervous system, no focal neurological defect.
Normally when you are seeing a supraclavicular node, you have to always examine the testis. It's very important because testicular mass patient you miss. Only evidence may be left supraclavicular node. Okay.
No signs of meningeal irritation. Coming to investigation, hemoglobin was 12.2 and platelet was 4 lakhs.
What do you think about hemoglobin percentage in this patient? Is it important?
Yes.
Why it is important? What is the expected hemoglobin in a real COPD patient? What happened to hemoglobin?
Increase.
Decrease.
Increase.
Increase. If it is not decrease, it has to increase. When there is hypoxemia, what will happen to your erythropoietin? Erythropoietin will produce more, and that will increase the hemoglobin. So normally, if you are following up patients with COPD, you can see that HB percent is very high. That is because of the secondary polycythemia. So in a patient who is having really COPD, somebody is having real COPD and his hemoglobin is slightly lower, you have to be very careful. That indicates malignancy. Okay, that indicates malignancy. So we have to be very careful when a lower hemoglobin in a COPD patient. There can be other reasons for hemorrhoids. All these things can also produce blood loss and anemia, but always you have to rule out a malignancy when the HB percent is low.
And neutrophil is 97 and lymphocyte is 8.5. Creatine 0.72, urea is 16.1, SGOT 29.8 and SGPT 30.9.
Okay.
Total bilirubin is 1.48 and total protein 7.4 and GRBS is 198.
198. Is a diabetic or non-diabetic?
Non-diabetic.
How do you know that he is diabetic or not?
It's a previous. No history of.
No, history will not be there. No, he is coming to the hospital first time. He doesn't know whether he is diabetic or not. How do you rule out?
HbA1c.
So you have to always ask for a HbA1c. Suppose it is more than 6.5, you can tell that there is a possible diabetes since last 3-4 months or more than 3 months. Okay.
And sodium is 130, potassium 3.3.
130 is slightly lower, not normal.
CRP is 243.
Okay.
And we did sputum AFB. The sputum AFB was negative and the sputum smear report was showing buddy yeast cell with pseudohyphae.
Okay.
Sputum culture report has grown Pseudomonas aeruginosa.
Okay.
And chest X-ray.
Pseudomonas is gram positive or gram negative? Gram negative. Pseudomonas normally occurring in a damaged lung. That is very important. That's why I told previously, whenever there is a damaged lung, if patient develops pneumonia, there can be gram negative organism. If the patient has already gone to many hospitals many times, then there is a high chance for multi-drug resistant gram negative organism like Pseudomonas. Okay.
Chest X-ray, left lower lobe of lung, cavitary consolidation.
Okay. Upper lobe cavity and lower lobe cavity, what is the difference? Upper lobe cavity, lower lobe cavity.
TB.
Upper lobe cavity is mostly due to TB or fungal infection. Lower lobe cavities are mostly due to infections, especially gram negative infections.
Diagnosis: lower respiratory tract infection, probably bacterial pneumonia.
Here you have to use the term necrotizing pneumonia. Why necrotizing pneumonia? That part of the lung is damaged and destroyed. Necrotizing pneumonia, very few organisms will produce, like Pseudomonas, Klebsiella, all these things produce necrotizing pneumonia. That part is lost. That's why there is a cavity there. Okay.
Fungal pneumonia.
Okay. We don't know whether fungus is there or fungus is a associated pathogen with the Pseudomonas. Already there is a cavity. So in that, whether the patient is growing fungus or only oral commensal, we don't know. But we have to treat the fungus also, because that also can produce a thick-walled cavity.
Underlying COPD.
Okay.
And BPH status.
So X-ray shows a cavity. It's a thick-walled cavity. That in that you are getting Pseudomonas infection in sputum, and you are also getting fungal hyphae in a sputum. Okay. But you have anemia. Patient is having anemia, is COPD. Still it can be malignancy. Malignancy itself also can produce cavity in the lungs. Okay.
Treatment.
Oh, so what treatment do you give for this patient?
Oxygen.
Why you are giving oxygen? He is already, saturation is low. He is having a lung cavity. Okay. So you have to start oxygen. Okay. What oxygen you have started? Oxygen, nasal bronchs or nasal mask or BiPAP? What you have started? Nasal bronchs. Okay. How much oxygen you can give through nasal prongs?
2 liters.
Up to 4 liters you can give. More than that, you should not give through nasal prongs. You have to put the mask. Okay.
Then IV antibiotics.
Can you use BiPAP in this patient or CPAP in this patient? What are the dangers of CPAP starting in this patient? This patient may deteriorate and sometimes you will have to start. But you have to explain everything to the patient by center. There is a high chance of there is a high chance of rupture of the cavity that can produce pneumothorax. Okay, but this is a thick-walled cavity. Rupture is unlikely. Very rarely it can produce rupture. So oxygen is started. Then
IV antibiotics.
what antibiotic you want to give? You want to give nebulization?
Nebulization.
As per your history, there is
Wheezing and crack.
wheezing. So you give nebulization. What nebulization? What all nebulizations you can give?
Salbutamol.
Salbutamol, ipratropium bromide. That is one. Then that is for COPD part and wheeze can be subsided with your ipratropium bromide. Okay, then he's having a cavity. Why cavity is formed in pneumonia? Because of the pus collected in the lungs. Pus will be very thick. What do you do for that? What are the broncholites? You know, broncholitis, mucolites. What are the mucolites? Ambroxol. You can give ambroxol tablet or you can give N-acetyl cysteine nebulization. Okay, he has got pseudomonas infection in that. So what antibiotics you give? What all routes you will select? Cephalosporin is not a good choice for pseudomonas. What are the drugs can be given in pseudomonas infection? We can give piperacillin tazobactam. There is one drug, or meropenem, piperacillin tazobactam, meropenem. The second drug can be amikacin or tobramycin. Okay. Third drug can be quinolones. Okay. These are the commonly used drugs. Okay. Quinolone alone will not be enough. You have to give piperacillin tazobactam with we have given tobramycin nebulization. So suppose this cavity remaining for a longer period, then you have to give a longer period nebulization with tobramycin. Okay. What posture you advise to the patient? Is postural treatment is required for this patient? Physiotherapy, lung physiotherapy. What you will advise?
Breathing exercise.
Breathing exercise is for COPD. COPD anyway we have to give breathing exercise. That is a different issue. That we have to advise the patient. But current problem is a cavity which is containing pus and fungus. How do you treat that? Chest physiotherapy is very important. Percussion of chest, vibrators you can use. Third thing is positional drainage, postural drainage. So suppose it's a right-sided cavity, you ask the patient to lie on the left side so that it will drain fast. Otherwise, what will happen? It will store in the cavity and it will become again it will become pus in the cavity. So we have to train the patient for postural drainage, such cavities. And mucolytics can be used. Okay, what happened to the patient afterwards?
No, patient was stable, sir.
Now patient is stable. Now how do you follow up this patient? Suppose he is stable, you start injection, patient has become better, patient will be discharged, he will come back for follow up. What are the important things you look in this patient?
Decreasing inflammatory markers.
Oh, okay, any infection we have to see the decreasing inflammatory markers. When will you take a chest x-ray? Chest x-ray should be taken ideally only after 6 weeks. Okay, if you want to see whether the lesion is increasing, you can take. Suppose you want to see the resolution of the x-ray, then it takes many days. So 6 weeks is the minimum time. So x-ray can be taken. Then there is another important problem. What that you have to see? Hemoglobin you have to see. Whether the hemoglobin is getting normal or becoming high, that is very important. If it is not increasing, you have to rule out malignancy. Then one more thing is there, left-sided supraclavicular node. If possible, you have to take an FNSC, then rule out malignancy. Examine the testes, ultrasound abdomen, ultrasound testes, all these things are important. Because suppose there is a testicular malignancy, this lesion can be due to malignancy. But normally malignancy with metastasis, what will be the character of chest? It will be multiple, that's why you told cannonball, multiple ball like this one. single lesions in metastatic lesion is not common, but this lesion alone can produce a lymph node in the left side. Okay, normally it produces lymph node on the right side itself, but sometimes it can produce left side also. Okay, so all these things you have to tell the patient on follow up. You have to do all these things. Okay, thank you.